Dr. Carmel.
Thank you, Dr. Lerner. It's a real honor and privilege to be here today. Not advancing here, folks. Yeah. And I thank SAGES for the invitation, and I am both honored and flattered to accept it. I'm going to talk about living with three-letter acronyms. And when I described to Dr. Lerner the acronyms I wanted to discuss, he said, oh, you have to add IPAB. So here are the acronyms, and the counting error there at the end is Dr. Lerner's. This is my day job. I'm a pediatric neurosurgeon. I'm the chairman emeritus of the department, and I am president of the American Medical Association. Most of you don't know the New Jersey Medical School, and this is our bucolic campus in greater downtown Newark, New Jersey. And I'm thrilled to tell you that since May, I've been an honorary alumnus of this medical school. This is the only note you have to take. For a copy of the slides, email me at carmel@UMD&J, University of Medicine and Dentistry of New Jersey.edu. There is a great deal of information on these slides that you may find useful. Let me discuss first Medicare. And that's because Medicare is the linchpin of healthcare reform. It's a compact between the nation and its seniors, and of course, since TRICARE is the same payment system as Medicare, also our military families. It is a promise that we will take care of the seniors' health care. But it is an open-ended pledge without limits, and it was intended to be funded by a payroll tax held in a trust called the Health Insurance Trust. It was adopted in 1965, and in 1965, eligibility was set at the age of 65, and life expectancy was 66. Let's pay for grandma for a year. But now, this year, the average American lives to 78, and grandma is living to the age of 83. That's a whole bunch of years that we have to pay for. In the beginning, there were only 19 million beneficiaries. By 2030, there will be 80 million beneficiaries. But the number of workers who are supporting that beneficiary is decreasing rapidly. And by 2030, there'll be only 2.3 workers for every beneficiary. This is how the Medicare Trust is funded. That bottom orange-colored area is the payroll tax, and that's what people believe pays for Medicare. But you can see that there's a whole layer on top of that. The next layer, the aqua layer, is premiums, like Medicare Plus. But from the beginning, that dark blue area has been payments from the general revenues. And from the beginning, Congress has added things to Medicare that come directly from general revenues. And you see that at this portion, there was almost a doubling of the money coming out of general revenue, and that was the Bush health pharmacy bill of his presidency. And you can see that Medicare is headed for a large area of deficit financing. In 2011, the average Medicare beneficiary had paid into the trust fund about $130,000 over their working life. But in 2011, a Medicare beneficiary took out on the average $410,000 worth of health care. That's not a good business model. And of course, everybody talks about how healthcare, our national health expenditures, are rising as a proportion of the gross domestic product. In 2011, it's estimated that it was just under 19% of every dollar produced in the United States. On this slide, and this is from the Kaiser Foundation, on this slide is something I find interesting and you don't hear mentioned very much, and that is that the rate of growth of health expenditures is really dramatically dropping for a decade. And nowhere is this more apparent than the drop in the growth of spending on physician services. And in fact, in 2010, the growth was only 1.8%, somewhat less than the GDP growth, and it was the lowest growth in 51 years. How are physicians reimbursed in Medicare? Well, you all know that. We are paid through the sustainable growth rate formula. And what that formula says is if Medicare payments to doctors grow more quickly than the gross domestic product, then the difference in dollars has to be subtracted the following year from physician payments. That has resulted in this ugly chart. The top line in black is the growth of expenditures per beneficiary, what Medicare pays for each person it covers. And over the course of a decade, that has grown by 60%. But physician payments have grown by a total of 0.23% annually. What business could survive if their revenues increased by less than 0.25% annually? And physician practices are small businesses. No business could survive on that payment model. It's not the same for all the other providers in Medicare. That top line is the payments to hospitals, up about 40% in the decade. Under that, we see the payments to skilled nursing facilities and long-term facilities. The heavy black line is the medical economic index. That's the cost to us of keeping our offices open. And that cost is up by 22% over the decade. But that bottom red line is how our revenues have increased. And in fact, as you know, we were scheduled for a 27.4% cut. That was supposed to take place first on January 1st and then on March 1st. And now the Congress, in its total ignorance, has kicked that can down the road so that on January 1st of next year, the cut will be 32.2%. That's the 14th patch for Medicare payment to physicians in 10 years. Every year that we delay the elimination of this flawed formula means higher costs. Back in 2005, we could have eliminated the SGR for $48 billion. As you can see from here, in 2012, it'll cost $320 billion. And if we wait just 4 years to 2016, the total cost is almost $600 billion. Let's put that in perspective. Our Deficit Reduction Commission in 2012 was supposed to reduce the total deficit by $1.2 trillion. In 2016, half of that will be due to the SGR. Only in Washington would you spend scores of billions of dollars to preserve a policy that's universally criticized, both by Republicans and Democrats. The bottom line is that our nation cannot climb out of its financial hole if we don't address the broken Medicare system. And the money to eliminate the SGR is there. There is something known as the Overseas Contingency Operations Fund. That funds things that the United States is doing overseas. CBO assumes in its projection that the present level of OCIO funding will continue for 10 years. We've already budgeted that. Yet our troops have been withdrawn from Iraq, and efforts are coming down in Afghanistan as well. This is what we're spending in the OCO this year. $126.7 billion. Until the next budget is passed, that means that the CBO projection is $1.26 trillion. So, right now, there is a unique opportunity to use the artificially high projections for the OCO to set off the artificially low projections for physician payments caused by the SGR without increasing the deficit and without any member of Congress having to vote for a single dollar of new spending. It's like when you played Monopoly. It's a get-out-of-jail-free card. We must have new provider payment models to improve our system, and we must have new delivery models to improve our system. And there is a new magic phrase in healthcare, as you all know, accountable care organizations. When I said that, those of you who have the ear of faith would have heard the celestial choir say, Amen. And look at this cover from Breakthroughs magazine. Look at the poor folks down there in the left-hand corner. They're so confused, they don't know what to do. One brave guy is running over the plank to ACO land. And look at the people in ACO land. They're so happy. No. AMA principles on ACO are simple, and the most important one is that physician and patient participation must be voluntary. Now, nobody knew what an ACO looked like. Because, in fact, although it's been discussed in the literature for 8 years, no one has really laid down the requirements. And so we were all waiting with bated breath for CMS to tell us what the requirements were. And in fact, when they released the preliminary rule, everybody was very disappointed because on March 30th, we learned all of those 18 bricks had to be in place to form an ACO, a level of healthcare accounting and records that none of us is capable of achieving. And even the most highly integrated advanced healthcare systems weren't able to deal with. So the proposal had features which limited its feasibility, and it wasn't attractive to the majority of physicians. And it said you couldn't share in any of the savings until a minimum of 2% of total costs had been saved. And so it would be attractive only to a few highly integrated entities across the country. Interestingly enough, it was released on March 30th. 6 days later, Mayor of Scottsdale made a public announcement that they would not form an ACO. So the AMA has suggested a number of changes, and I have to thank the ACS, which I'm a member of and very proud of, because they were a good partner in doing this. And we sent CMS a 14-page proposal of changes for ACOs. And sure enough, when the final rules were released, almost all of those changes had been accepted by CMS. So doctors could participate without financial risk. We could share in savings generated from the first dollar. We could reduce the number of quality measures that were needed, and it gave practices more time to be involved. And best of all, CMS will provide $170 million in upfront capital to help physician practices and rural community hospitals start ACOs. These changes will enable physicians of many different types and practice groups to join ACOs. Let me get to quickly implementing ICD10. ICD10 is the latest international disease classification. It was started in 1983 and was finished in 1992. It's already a generation old. For HIPAA reasons, you have to use version 5010, and we are now trying to implement e-prescribing, EMRs, and HIPAA 5010 simultaneously. I was personally called out in Health Leaders magazine in their January issue. They quoted me as saying, coming in the midst of huge HIT change with its large expenses and practice disruptions, the imposition of ICD-10 at this time poses an onerous burden for physicians. Health Leaders responded, it's not onerous. These are folks who've never filed a claim in their life. And they advised us to stop the sobbing, screaming, and procrastination. Well, in fact, with the addition of ICD-10, EMR implementation for a practice of 3 doctors will cost $83,000. And look at this comparison, ICD-10 9 on the left and ICD-10 on the right. ICD-9 is what we're currently using. 14,000 diagnostic codes, that rises to 68,000 or 5 times. And procedure codes rise from 4,000 to 87,000. That's a 22 times increase. I know onerous when I see it. In response to the AMA letter, Janet Tavener came to our meeting in Washington at the National Advocacy Conference, and she announced that CMS will delay and restudy the possible implementation of ICD-10. Let me get to IPAB, just for Dr. Lerner. IPAB is a 15-member executive agency, and it must cut Medicare spending to reach predetermined targets. It cannot ration care, raise revenue, or change Medicare premiums. They can only cut provider payments. But clinical labs are exempt until 2016, and hospitals are exempt until 2020. The IPAB's only real tool is to cut physician payments. AMA policy is simple, repeal the IPAB. That's our official policy. And when we adopted that in June of last year, I thought, well, you know, I don't know if we have a great chance. But a funny thing has happened. Congress has discovered that nameless, faceless bureaucrats cutting our payments are making fiscal policy, and they don't want that. And you can see this quote, I see no reason why Congress would or should hand that authority over to the executive branch. And what member of the Republican Party do you think said that? Pete Stark, Democrat of California. That was at last week's Ways and Means Committee meeting, and the Ways and Means Committee voted out a bill repealing IPAB. This quote that says, IPAB, like other independent commissions, encroaches upon the legislative authority. And the person who said that was Frank Pallone, Democrat of New Jersey, who is the ranking member on the Energy Commission, Committee, and they're the next ones to vote on IPAB. So, other recent AMA successes I'll go through briefly. Let me tell you about the lame duck session. Those of you who are political junkies, hang on to your hats, because the lame duck session is going to be an act of political theater. The Bush tax cuts expire at midnight, the 31st of December. Large defense cuts due to sequestration are there, Medicare cuts to all providers due to sequestration, and Medicare physician cuts of 32.2%, and the payroll tax relief expires. The debt ceiling will also have to be raised. It is going to be an incredible performance. Going forward, let me just point out all of these websites that have answers to these important questions. Doctors need a timely, reliable, and trusted source of information. We have the information and resources you need, and we're there to help. In the last 3 years, the AMA has repeatedly been successful in protecting and advancing the cause of physicians and the practice of medicine. Here's the grassroots hotline to call Congress. One final word, join the AMA. Thank you very much.